Welcome. My name is Jen Hastings. We're really happy to have you join us today for another, I hope, exciting and informative continuing medical education. Great to see you all here. The neuroscience of pain and addiction is the topic today, and we hope you get a lot of great information to bring home to your very different workplaces. I want to introduce Dale Bishop, who will talk a little bit about the efforts from Central California Alliance for Health.
Thanks, Jen. Welcome, everyone. It's great to be here today. And I was looking at my notes yesterday about how many of these pain programs we've had now. We started in May of 2015. This is actually the 5th in the series. I think some of you have actually come to all 5, and thank you for coming to these. We hope this will be really interesting today. We're sure it will be. I was looking at some of the results from the utilization of narcotics and analgesics since 2015, and we've actually seen in our region a 37% decrease in the number of prescription per 1,000 with the Alliance over the last several years. That has translated into, especially in Monterey County, with their Monterey community efforts through the Prescribe Safe Now, Monterey County, that the deaths from opiate overdoses have decreased significantly in Monterey, and we're starting to see some of that going on in Santa Cruz too. We're hoping to get some of that translated into Merced. But in order to get these population health victories, which we've seen, and to continue them, we have to do a really good job with individual treatment, and that's why we're here today, to learn how to do a little bit better and do more with the neuroscience of pain and addiction. So I'm going to go ahead and introduce Vanessa de la Cruz, who's going to be speaking on neurobiology of addictive behavior. Thanks.
Good morning, everybody. I was hoping we could start if you could raise your hand if you are a primary care provider. Okay, raise your hand if you're a behavioral health, a mental health provider. Okay, and then raise your hand if you work in substance abuse treatment. Okay, so we have a great mix today. I'm going to be talking about the neurobiology of addiction. And to start, is a little bit about the word addiction. Most of my talk is about the dopamine reward pathway, and it's in the resource page. It's all based on one article, and in that article they use the word addiction. So I'm going to use the word addiction. But I do want to acknowledge that we tend to say now substance use disorders. I think language is very important. I don't have so much problem with the word addiction per se. I think the word addict, though, is more challenging. There's so much stigma, as you all know, around substance abuse and mental health disorders. So there's a lot of reason why the language is important. So I wouldn't refer to my patients as an addict. And I wouldn't, when I ask my patients, oh, was your urine tox screen? I'm going to say, was it negative? I'm not going to say, was it dirty? Or was it clean? Because obviously there's a lot of emotion around those terms. So addiction can be defined as compulsive drug use despite negative consequences, and we're going to get more into this as we go along. The other thing I would say is, think of depends on your level of experience. This is either going to hopefully be a refresher or a review to prepare you for the subsequent talks that you're going to hear after mine, or maybe this will be your introduction to the dopamine pathway. But Rachel, who speaks after me, is going to kind of take this to the next level. And also to say, I'm an addiction specialist. I'm a psychiatrist and I treat addiction. I don't treat pain, and I don't prescribe opiates for pain. I do prescribe buprenorphine for opioid dependence. The reason I'm kind of calling that out is I think sometimes there's this question, is this a pain patient? Are they addiction patient? Has their pain disorder and their opioid use transferred somehow into the addiction realm? And in some ways, I don't know if that really matters. But it really matters often to the patients. And even as a buprenorphine provider on the addiction treatment service at the VA, patients would tell everyone I was their pain doc. So you get it. I mean, it's all about stigma. We have a lot of time to get more into that, and especially with the cases towards the end. So physiologic dependence and withdrawal avoidance alone can't explain addiction, and this is why detox doesn't work. It's not a treatment for a substance use disorder. It's often necessary medically, sometimes even to save someone's life, but it's not going to treat their actual addiction disorder. And so this, again, probably the first half of my talk is going to talk about the dopamine reward pathway. It can kind of explain the mechanisms, some of the mechanisms by which drug-seeking behaviors are consolidated into compulsive use. And this explains the long persistence of relapse risk and some of the drug-associated cues that control behavior. And why is this important? Why are we having this conversation? Again, I mentioned stigma. I think understanding the dopamine reward pathway, this schema or schematic, can help us have empathy and compassion for our patients. People who are struggling with substance use disorders can be very frustrating and challenging to work with at times. And sometimes if you can kind of remember what's going on in their brain, it might help you connect with your empathy and compassion for what they're struggling with. At the same time, I think sometimes people talk about the hijacked brain. It's really important to maintain your limits and boundaries working with this patient population. Their addiction is almost very adaptive. It's going to do what it can to sustain itself. So these patients are going to push you and ask you to do things that, prescribe more, please don't cut this medication, that kind of thing. So that's an important piece. We're going to talk a little bit about harm reduction, fostering recovery. And then again, like I said, this is really my talk is a warm-up for the next two speakers. Got a lot of really cool stuff today. So all the addictive drugs are pharmacologically diverse. I don't necessarily have to go through all of them, but they all have different mechanisms of action, whether it's the stimulants, the opioids, the sedative hypnotics, or even cannabis. But they all lead to a common pathway. All addictive drugs pharmacologically release dopamine in the nucleus accumbens. So here's my brain picture. I'm really not going to spend too much time, but it's just there's the nucleus accumbens. You notice there are neurons that extend into the prefrontal cortex and also to the amygdala. And again, that's going to be more important a little bit later today. So dopamine. Dopamine's required for natural stimuli, such as food, opportunity for mating, to be rewarding, and to drive our behavior. So you kind of think of the caveman and survival of the species. So natural rewards, just like that cocaine or the opioids, they cause dopamine release in the nucleus accumbens, and addictive drugs cause dopamine release in the nucleus accumbens. So addictive drugs mimic the effects of natural rewards, and they shape our behavior. So survival demands that organisms find and obtain the needed resources, such as food or shelter, and opportunity for mating despite risks. So these are all survival-related goals. And these goals all have natural rewards, right? You get to eat the food, you get to have sex, you get to have a nice, dry, warm place to sleep at night. And that these behaviors that are rewarding persist to a conclusion, and they increase over time because they're very positively reinforcing. I think we kind of hopefully understand that concept. And then it kind of makes sense, but internal states can affect the value of the reward. So if you're very hungry and you finally get to eat, even if it's not your favorite food, it tastes really good, right, if you're really hungry. And then another part, the value, I would say, of dopamine is it increases the likelihood that complex behavioral sequence, such as hunting, will be brought to a successful conclusion. It also increases the likelihood that a complex behavioral sequence, such as obtaining and using drugs, would be carried to successful completion. So another piece around this is that these behavioral sequences that are focused on obtaining a reward, they become overlearned and automatized, which is a good thing, saves us some time and some mental energy. And then automatized behaviors, these repertoires can be activated by cues that are predictive of the reward, or these are the classic trigger. So I'm going to go through this. I'm going to draw a little picture to explain this. Exposure to an unexpected reward causes a transient firing, an increase in firing of your dopamine neurons, which signals the brain to learn a cue. Once the cue is learned, so the next time you see the cue, the dopamine firing occurs at the cue, not when you get the reward. So that's a positive predictive signal. Now, if you get the cue, you have that increased dopamine firing, and then you see you don't get the reward, there's decreased firing. So that serves sort of as an error signal for you, that I didn't get the reward. So it's kind of, and then if the reward comes at an unexpected time, the dopamine firing will increase, because it's called a positive predictive signal, and I'm going to tell you about the error thing in just a moment when I draw it. It's like, oh, this was better than expected, great. So if this line is your baseline level of dopamine firing, and we're going to have a cue here, and this is the reward. And my reward, if you came into the room and I was standing here and I had a huge plate of chocolate chip cookies or whatever your favorite cookie is, when you walk in the room and then you see that plate, you get that plate of cookies, it's a great surprise, and so the firing rate goes up. And that signals to your brain to learn a cue. And so maybe that cue is she's wearing an orange sweater. So the next day when you come in, I've got the orange cardigan on. And so your brain, the dopamine firing is going to increase here. Because like, I'm going to get the cookies, I'm going to get the cookies. So here was a cookie, and we're going to get the cookies again. But now the cookies are just their own reward. You don't get any extra firing right here. The firing happened when you saw the sweater here. Now, if the next day, come in, I'm wearing the orange sweater again, you get all excited, there are no cookies. I let you down. Then the rate of dopamine firing is going to actually decrease. So now we're going to get to the part when you do drugs. So if you do drugs, they all cause this dopamine release. That's really great. You're going to learn a cue. But then when you do the drug again, instead of having this baseline firing, it's going to go like this again. So it's saying that's better than I expected. Better learn a cue. And so you can see that just repeats over and over again. And somebody pointed out to me yesterday, sometimes people who use drugs will say, I'm not using to feel good anymore, or it doesn't feel good when I use. So one, just to acknowledge this is a schematic oversimplification, but at the same time, this signaling, learning, this is all about learning, this still can be occurring. So because, I'm just going to repeat, because the drugs cause this dopamine release, because of their pharmacological actions, the firing doesn't decay over time. It occurs every time they use the drug. And the brain repeatedly gets this positive predictive error signal. Wow, this was better than I thought. Drug cues become ubiquitous, and they're difficult to extinguish. And just think of your own, I don't know, when I was in medical school, we studied in coffee shops all the time, so a lot of positive association around that. But if you drink coffee late at night, then you don't sleep, and then you can't study, go to class, whatever. So I would literally be driving around town to go somewhere at 11 p.m. and drive by a coffee shop, and I could just oh, maybe I could just stop for a second, But then, no, I don't, I need to sleep tonight. But I can that's my kind of appreciation what a cue might feel like. And these cues that predict availability also take on an enormous incentive salience. They become very focused and specific. I'm going to get the drug. So that helps consolidate the drug-seeking behavior, just like helping the caveman consolidate all the complex behaviors required to hunt, for example. And they also become powerfully overweighted compared to other choices. And this contributes to the loss of control over drug use. And there's many more layers to this, and you're going to learn a little bit more about the difference between D1 and D2 receptors in the next talk. But just the overweighted part, this explains, which is why people choose drugs over all the other good things in life, like maybe their jobs, their important relationships. And this explains one way of explaining why a mother might choose using drugs over her children. And so that's where I'm getting back to that compassion part, because I think that's sometimes that type of thing can be hard to take. This slide I've just put in there to talk about cue learning. It's not, again, so simple as just the dopamine. Glutamate is another excitatory neurotransmitter that's involved in cue learning. It helps code specific information about the cues, the evaluation of the significance, that salience part, and also the learned motor responses that follow. Basically, it just enhances dopamine-dependent learning. So what are the clinical implications of what I was just talking about? So addictive behaviors are an important and normal part of human behavior. Addictive drugs pharmacologically modify the functioning of these reward circuits to overvalue the drug rewards and reduce the comparative value of other rewards. And also, this is the big intention to stop use is not enough to stably quit. This is why we need to help our patients who are struggling with substance use disorders. So I'm going to talk a lot, my next part is we're going to talk about some of the treatments, both pharmacological and behavioral. And that, as we'll kind of go on to discuss, some of these treatments can be used for somebody who's not, again, officially, is this a pain, they're just some trouble with prescriptions, they really have this pain disorder. They could use any of these pharmacological treatments. So medication-assisted therapy, I think everybody knows what that is. The medications we use for MAT are naltrexone, brand name Revia, in the oral form. Then there's the injection, there's a spelling error there on the Vivitrol. Is the injection form acamprosate, brand name Camprel, disulfiram, buprenorphine, which is Suboxone or Subutex. And we'll talk about that in a moment. So naltrexone or Revia is an opioid antagonist. It literally blocks the receptor. It prevents the dopamine release normally produced by alcohol consumption. So you don't get the reward when you drink. So it makes drinking less desirable, and it seems to lead to an extinction. People drink less, and they have less alcohol-seeking behaviors, less binge drinking. And although mechanistically there's not a reason that it should reduce cravings, patients seem to report that. I'm not going to disabuse them of that notion if they feel that it helps. It's dosed daily. It really has no interaction with alcohol, so it's not going to make them sick if they drink. And you could start it the next day after they had their last drink. I think in Europe, some countries actually have the patients take the naltrexone before they're going to go out where they know they might drink alcohol, and it seems to reduce. But I've never prescribed it that way, so I don't know as much about that efficacy. It is metabolized by the liver, but I've had a lot of our folks who are struggling with alcohol use disorders or have liver disease, and when I've talked to liver specialists, there's weigh the risks and the benefits. And the rule of thumb is it's generally as long as their AST, ALT are no more than 3 times elevated, it's worth the risk of prescribing a medication like this. And the same thing for buprenorphine, which is processed by the liver. So the injection, the Vivitrol, is the same profile, except it's a long-acting injectable. This one is also used for opioid dependence or alcohol use disorder. The idea being that the naltrexone as a pill for the opioid dependence, you have to decide to take it every day. So if you wanted to use opioids that day, just skip your dose. So it doesn't seem to be as effective. I've also heard people with opioid use disorder, they do like this because they have to make one decision every month, which is to get their shot. Again, this doesn't necessarily deal with the cravings, the opioid cravings for the patients. And my one risk, the main risk, it's overall low risk other than some injection site reaction, is you could precipitate withdrawal. So I had a patient, when I worked at the VA, we had a 28-day rehab. We had a patient who was in treatment with us for alcohol and cocaine, and we had started him on the injection. He lived pretty far away from the VA, but he came back to see his primary care doctor, and he called me. He's like, I think I'm due for that shot. Can I get the shot again? So I said, sure, and I put the order in. And a couple hours later, got a call from the ER, and they're like, your patient who got that shot, I think he's having a reaction. But what it turns out is, I thought, in my mind, I said cocaine and alcohol were the problems. He'd been taking his neighbor's morphine daily, and so basically he got the shot to put him in withdrawal. So he was pretty uncomfortable for a while. So got to be thorough when you ask those questions. So acamprosate or Camprel is what we say pharmacologically messy. It affects both the glutamatergic and GABAergic systems. And this one is supposed to reduce cravings. This is, traditionally you start this in an abstinent patient to prevent relapse. Fairly low side effect profile. This one's processed by the kidney. The biggie though is it's dosed TID, which I think can be a challenge. But somebody who takes, for example, if you had an alcoholic who had a reason they were taking opioids, this won't be a choice, because obviously you can't take naltrexone and a pain medication. So disulfiram, or also known as Antabuse, this is the one is an aversive agent. It makes you sick if you drink because it inhibits acetaldehyde. So all those alcohol byproducts continue to build up. It causes flushing, nausea, and palpitation. So to avoid being sick, people obviously avoid drinking. But it only works if you take it. And it works best if dosing can be observed. So there are studies, and I think it's almost like 100% efficacy if you take it in front of your parole officer. There are other, and I'm going to talk a little bit more about it later, but there is a behavioral couples therapy where you take the disulfiram in front of your spouse. And the idea is that the person with substance use disorder takes that disulfiram in the morning, and the spouse says, "Thank you, honey, very much. I'm proud of you." That's it. You don't say, "Hey, you left the toilet seat up and your underwear is on the floor and it's your turn to empty the dishwasher." You want to be positive association with taking that pill every day. You do have to be abstinent for 24 hours to start. Some folks some people, obviously they can't drink alcohol, so you recommend not using any alcohol-based mouthwash. Some people, even if they spray an alcohol-based perfume on their neck, will start to get a little flushing, but not everyone. So I want to say, if you spray perfume in your neck and you don't have a reaction, it doesn't mean you can drink. But it's just, everyone's a little different. And and you also don't start drinking until you've been off for 2 weeks. But I've had patients tell me they can start drinking before that without getting sick. So it depends. But I guess the biggie is just that you do have to take it every day. And there's something called in the addiction treatment world of stinking thinking. So it's just that you forgot to take it one day, and then the next day, maybe I'm coming down with the flu, I shouldn't take it today. And kind of lo and behold, now all of a sudden you've strung 3 or 4 days together. So again, that's the challenge with this medication, is that you have to take it every day. Opioid replacement therapy. So in the United States, we use methadone and buprenorphine. And basically, I have on just this slide. All these treatments are most effective when they're combined with some sort of counseling or behavioral intervention. And we'll talk about monitoring. So methadone is long-acting opioid. It has a slow onset. So that's kind of the difference between taking methadone versus getting high, is because of that slow onset. You're going to get less of that sort of kick, euphoric kick. But methadone, it interacts with a lot of medications. You have a risk of prolonged QT. For opioid replacement therapy, you have to get methadone from an NTP or a narcotic treatment program. A little bit about side effects. So there's something to be said. You have to go in every day to get it, which can be challenging, especially if you're getting back on your feet, you're working. I know sometimes when I have patients who have sales jobs and they need to travel, this can be a big challenge. That being, so then we can move on to buprenorphine. It's a partial opioid agonist. It's less reinforcing. It's a partial agonist. It's less reinforcing, so again, less euphorogenic, less sedating. And you can give somebody a 30-day supply, which can be really a lot easier. For people's lives in terms of their working. It has a very long duration of action, so if you miss a dose, you have a little more protection, shall we say. And Suboxone is buprenorphine that's coated with naloxone. That's put solely as a deterrent. If you crush up your Suboxone, that Narcan, and you inject it in your veins, it'll inactivate it, just the way giving someone a Narcan shot would. Now, buprenorphine is a little tablet or strip that you put under your tongue, and it dissolves under the tongue and is absorbed by the blood vessels there. And so the Narcan is not absorbed at all. That being said, out there in the kind of community of folks who use buprenorphine, Suboxone, you hear this over and over again. Suboxone doesn't work for me. I have side effects. It makes me sick. I'm allergic to the Narcan. I don't know why this value of getting just the regular Subutex, which is just the buprenorphine, but it's really strong. But when I worked at the VA, they have an absolute policy. The only way you could ever prescribe Subutex is for a pregnant female because of concerns about causing withdrawal in the fetus. So I had to switch a lot of patients over who'd been taking even Subutex for years. Nobody had any problems, but. Oh, and another piece, so the buprenorphine is another thing I like to describe is, this is the schematic for patients. this is not representation of what the receptor really looks like. But that if this is like, I usually have my fist, but I'm going to be holding this. So if this is the dopamine receptor in your brain, this is morphine, this is heroin. They all bind the entire receptor. So you get euphoria, you get sedation. You know, if you get too much, you can stop breathing. Where the buprenorphine is a partial agonist, it doesn't bind the entire receptor, so it's less sedating, yes, less euphorogenic. But it also binds more tightly than any of the other opioids. So if you had morphine in your system and then you took buprenorphine, you're going to go from full to partial agonist, and it'll feel like you're in withdrawal. And that's that part about when you're in, we're not going to talk about induction today, but that's when that comes into play. So it's much safer because it's a partial agonist, but there have been some deaths, and usually the deaths is when it's being combined with other drugs. There have also been deaths of children, accidental ingestions. I had a patient who took the med out of his medicine cabinet, put it on the sink, closed the medicine cabinet, and his 2-year-old had already taken it, put it in her mouth. So they did go to the emergency room. She got Narcan. He actually brought her into the next appointment, so like just to show she was okay. But I think it's a pretty important cautionary tale. If your patients live anywhere where children are present, they really need to lock up their medication. There's also been reports of people who accidental ingestion by pets. Dogs don't seem to do too well if they eat your buprenorphine. So I had this one to compare methadone and buprenorphine because sometimes people might say, well, why everyone should be on buprenorphine, it's safer, it's easier, it's not interfering with people's daily lives. But there's something to be said about the methadone and having to go to that clinic every day. People are at high risk for diversion. Methadone it's liquid, it's observed each dose, so it's much harder to divert. It doesn't mean people can't divert. Definitely no patients who, I don't know how they hit it, and you just go and spit it in a bottle, and there's a market for that, or you save it for yourself. And then when I worked in New York, I worked at a shelter for men on methadone, and we converted a lot of our patients to buprenorphine. And I had a few, everyone wants to get off the methadone. Who wants to go to the methadone clinic every day? What a drag. But I had a few patients actually that really realized that that had become their life and they missed it. And they wanted to get back on the methadone because I think that, well, we can talk about what their quality of life, that was such an important connection for them. So just something to be mindful about. So it's not just all about medication. There are also behavioral treatments for substance use disorders, obviously. And I'm just going to talk, again, prep you for some of the later discussions, and also I think this, keeping the dopamine reward pathway in mind. So motivational interviewing focuses on exploring and resolving ambivalence. It centers on motivational processes within the individual to facilitate change. So it supports change in a manner that's congruent with the patient, the person's own values and concerns. This is not, hey, you know what you need to do? You need to stop doing that. You need to stop talking to those people, you need to get away from her, or you need to get a job. This is about what the patient, what their goals are, and helping them plan and make steps to those goals. So they might not want to quit. They might want to cut back or reduce the amount. We're going to talk a little bit more about this as we go on. Behavioral couples counseling, this is the one I talked about earlier, that can sometimes be combined with the disulfiram treatment. It focuses obviously on reduced alcohol or drug use in the identified patient, but also improving overall relationship satisfaction. They're usually behavioral assignments for the couple to work on together, to improve communication, shared activities, but it may include a sobriety contract. And depending on that contract, there might be requirements to attend the therapy, to do urine tox screens, or to go to 12-step, or whatever other treatment might be involved for the particular patient. So community reinforcement approach. This is actually a comprehensive cognitive behavioral intervention. It's usually done in a group format with also individual components, and it focuses on environmental contingencies that impact and influence behavior. So basically, you've taken away a very rewarding behavior, which is the drug use, and you've got to figure out how to build that back in. So there's a lot of focus on job training or returning to school, because the idea that a reward of a successful career, that's some of the good stuff. There's a lot of focus on relationship therapy, because that's another rewarding thing in our lives. And then there's a recreational component in terms of finding recreational activities that don't involve drugs or alcohol, and people to hang out with who are not using drugs or alcohol. So like there might be, camping trips or, group outings for that. And contingency management, this is paying people for clean urine. There's tons of data to support it. Most programs don't give people cash. Usually you get, coupons. One clinic at the VA, I saw them do a presentation. They had a prize closet, and depending on what you drew, what shelf you got in the closet, it could be everything from toiletries to gifts or coupons. I was at a substance use treatment presentation at the VA, and that same group who presented on the prize closet, and they actually had some of the nurses and MAs who did the collection of the urines. And they talked about how when they decided to do contingency management at this clinic, that the staff was really against it. Why are you paying people for clean urine? But what they said was they became converted, is they used to be the police. People came in, they're unhappy, they have to pee in a cup. The staff has to stand outside the bathroom door to make sure, see if they can detect any tampering. But this was like, hey, your urine was negative, you get a prize. They said their jobs completely changed. People were so excited to come and pee that it was a really positive thing. So, and that there's a lot of data around using this for stimulant users. So it's positively reinforcing, right? 12-step facilitation is just a form of, it's a manualized treatment, and it can be done individually or via the telephone in terms of just facilitating and encourage someone to attend 12-step groups and also to participate, in working the steps, getting a sponsor and the like. There's evidence base for that. There was recently an article, I think it was in the Atlantic Monthly, it was just very anti-AA. And I want to say, and I get it. I mean, there's the religious part. Many AAs will tell people you shouldn't take any medication at all. So as a psychiatrist, that can be challenging when they're like, my AA group is telling me not to take my psych meds, which I might disagree with. But I say, if your patient reports a negative AA experience, I'd say, try to find another one. Especially here in the Bay Area, we have a lot of options, and maybe they just didn't find one that was a good fit for them. That being said, I took care of a veteran who lived in Eureka, and there's only one group, and the 2 homeless guys in town went every time, to get the donuts and coffee. That wasn't a good fit for him. So just to acknowledge that, but here in California, we've got a lot of mindfulness-based meditation or other different ways to focus on recovery. So a psychologist I work with at the VA used to say there are 50 ways to leave your lover, and there are 50 ways to get sober. So we've got lots of options. And I think that's back to this motivational piece around, it's not about telling our patients what they need to do. It's kind of helping them find out what works for them. So now we're at, these are just my resources. That's the first one is the article. I think if you printed out the slides that they had sent out last week, they're pretty much the same. It's just that was an animated version of the PowerPoint, and it was driving me crazy. So that's just pretty much different font. The second article about confrontation in addiction treatment is about that kind of old school idea. You have to hit bottom, and you kind of got to yell at people and tell them where they are. Obviously, there's no data or evidence for that. And thankfully, it's going out of vogue. But if you're encountering that, I think sometimes it's important. If you have those sheets in your packets about empathy and compassion, there's a thing about systemic empathy. And sometimes it can go from physician to, the clerks at check-in of this, they need to follow the rules. We need to tell him what to do. Like, he can't be doing that. So it's a really great article about why confrontation in addiction treatment doesn't work. And I have a little time for questions, right?
Just a quick one. What's the cost of Vivitrol now? Because it came out incredibly expensive when it was first released.
So my understanding is if it's prescribed in mental health, right? If we prescribe in specialty mental health, then it's covered by Medi-Cal. And can primary care now prescribe it, and it's covered by Medi-Cal. So I don't know the cost. Yeah, it was like $1,000 an injection, I think.
So I have patients from Methadone clinic. They take 60, 80 milligram, and then they also supplement themselves with some opiates as well. And their clinic told us that they should get the opiates from our clinic or other clinics. And what do we do about those kind of patients?
You mean in terms of when there's diversion going on?
Yeah, well, they're already on the program for for these medications already, methadone already, and it seems like they tend to supplement themselves with opiates on top of that, Norcos or Percocet and those kind of things.
So yeah, and there's a phenomenon for people who are on methadone, where some people even inject heroin on top of that. That's called chipping. Scares me to death. That's a lot of opioids in someone's system, and so you have to be careful about calling methadone a harm reduction treatment, because many would say, hey, this is a biological treatment for a biological illness, just like insulin is treatment for diabetes. At the same time, if that person is not injecting heroin because they're taking that methadone every day, it's unfortunate they're still using Norco on top of that, but big picture, it's safer. Same thing with buprenorphine. There's a lot of diversion with buprenorphine. But some would say we'd want more buprenorphine out there in our community than all of the other opiates. And I actually had 2 buprenorphine patients who kind of tacitly acknowledged that they shared their meds. If one ran out, they'd kind of spot each other. And then one of them pissed the other off, so he broke in his apartment, and it was kind of a weird situation where they were both kind of telling me from the other side, and I couldn't obviously share that I knew that. Did you?
I think I'm going to take an opportunity to try to clarify this question, because I've received this letter from Janice, which is our local methadone clinic, and it says that methadone is not intended for pain management, and these clients are then coming saying that they told me I should address my pain with you at my primary care office, and that you would be able to provide me with that opiate. And so I think that's the question is, these people are on opioid replacement therapy. They're being told potentially by somebody at Janus that they need to get their pain managed, and their perception is that their pain should be managed with additional opiate. And that's kind of the challenge, I think, that we're being presented in primary care.
And I think that's it. Back when I said at the beginning, like, I kind of don't care if it's a pain patient or an addiction patient. Patients care, and unfortunately, our funding streams often care. And so which bucket you put them in, or the regulations seem to matter. And if I've had this was back when I was at the VA, patients who just had candidates for methadone written all over them, and they would go, I'd get them hooked up with the methadone clinic, and then they'd show up on that first day and say, yeah, I have a pain disorder, and I need methadone. And so the methadone clinic would say, no, that's not what we do, and send them away. So I think that language piece can be challenging. And I know that Janus also has some requirements and some of the wording on those letters, but I think that's important to have that conversation.
But I think collaboration, us working together with Janice about these conversations and not sort of continuing to silo ourselves, but Nancy Krause is here from Janice, and I think we should be working together and maybe do case conference, collaborate together about individual patients where there is addiction and pain going on, and that's actually, in my experience, a large number of our shared patients. So let's work together. Let's not keep sort of being annoyed at the other person or something. I don't know.
So we had a question here.
Yes, please.
I think one of the hard parts about treating people with opiate disorder is the lying. And with any addiction, it just seems like another one of the symptoms. But then when you ask your staff to be empathetic and you ask residents in training to be empathetic, I don't really know how to teach that. I don't really know how to help the provider, the staff, think about the lying in a way that's empathetic.
So and I'll delve a little bit into the mental health side of the house, is that a lot of people who are struggling with substance use disorders behave in ways that are similar to borderline personality disorder. I mean, they're very labile emotionally, and you're the best doctor ever kind of thing. But I think basically all these behaviors around using, lying, misrepresenting, stealing prescriptions, all of that, it's all about maintaining that behavior. So if you can remember, this is their dopamine pathway has been altered, probably permanently. And while they're in the midst of it, that's when these behaviors show up. And then I've taken care of patients in recovery, and sometimes it's hard to distinguish. They'll start manipulating me just, to talk or, for the past or something. It's just like, it's really hard to turn off. They learned it. It was very adaptive on the street, and it was very adaptive for their disorder. So it's kind of like reteaching them those behaviors. I know some treatment programs, residential programs, spend a lot of time also just working on, hey, you got to get up in the morning, you got to be on time. If you're running late, you call. And you say, I might not be there. So just kind of relearning a lot of basic skills. So that's again, that's one of the reasons about learning this, is to help you and others connect with the compassion. And that's the reason I've kept this so simple. I just really didn't want to complicate it.
That's why 12-step programs focus so much on rigorous honesty as one of the big things to relearn for addicts. But what I wanted to mention is about treating pain. Obviously, addiction is can be very traumatic lifestyle, and there's a lot of people with chronic pain. But word to the wise, the medical board, at least in California, is very anti-doctors treating patients with addiction with opiates, unless it's buprenorphine or a methadone clinic. And if you do that, which I did, this is experiential learning that I'm sharing, you can be severely punished, shall we say, by the medical board. I treated a number of patients with chronic pain and opiate addiction with methadone because it seemed like a win-win back when Medi-Cal wouldn't pay for long-acting morphine or oxycodone for pain, and the medical board took great exception to that, even though it's legal. But the 2/3 majority of non-MDs on the medical board was quite upset that that was being done. So.
And that's, the lines are blurry, but there are rules that really want you to put people in buckets. One more question?
Just going to go back to the issue about teaching compassion, and I just wanted to say one of the things I think about with patients, and I don't have a ton of experience yet, is potential for having had trauma history. That changes my whole approach and attitude, or it brings me to the right approach and attitude where I can tap in quickly to my compassion. Is it true that so many of our
there are
patients...
other studies about that having not just PTSD, but like having a depraved environment, like growing up in an environment with neglect and violence, actually sort of prime the pump, and that you're already starting, your dopamine reward system's already affected. So it makes it even more likely that the drugs or alcohol are going to become a problem for you. So great question.